Olá, me llamo Luciano Chala. Primero les doy la bienvenida a este webinar tan especial. Também quero agradecer a Bayer por seu apoio para que este webinar fuera posible. E, finalmente, quero invitar a minha colega Dália Avedanho a apresentar a nossa invitada especial desta noite. Dália.
Thank you, Luciano. Hello, everyone. I'm Dr. Dalia Vendaño. It's a real pleasure to moderate this 2025 tier webinar. And in this session today, Ultrafast and Abbreviated MRI. So our speaker today needs no introduction, really. Dr. Katja Pinker is one of the leading figures of advanced breast imaging worldwide. Currently, she's serving as Chief of Breast Imaging at Columbia University, and also is adjunct professor at Medical University in Vienna. Her work is based in advanced MRI, hybrid PET MRI, and AI-driven imaging biomarkers, and has shaped much of what we know today about precision medicine in breast cancer. So she's also a mentor and a role model to many of us working in this field, and myself included. So Katja, thank you for being here. We are looking forward for the talk today.
Thank you very much for the kind introduction. So let me start. I cannot share. Someone else is sharing. I'll see if I can replace the request. That seemed to have worked. Can I see my screen?
Yeah.
Perfect. Wonderful. Okay. Thank you very much for the kind introduction. Well, it's a pleasure to talk to you about one of my most favorite topics, abbreviated MRI, ultrafast MRI. So in general, MRI today, what we can do, and already in the clinical practice, I think we have translated cutting edge imaging into clinical practice. And I want to start take one step back and start to talk basically, why do we actually miss cancers with a mammogram? Well, mammography is like a 2D picture of a 3D image where there's superimposition and masking. And I mean, we all know that when it's very dense, the sensitivity of mammography goes very low. So we have to offer women better tests. Yeah, we have poor contrast. There's tumor growth patterns are hidden in the anatomical noise. And I think this is the most important thing. There is no functional information. So that is what we need to cover. And not only increases the sensitivity, also the risk of a woman of having basically getting a cancer reduces with breast density. So this is one of the pictures where I think really highlights why we have to go into functional imaging realm. These are both breasts. In both breasts, there is a cancer, which with an MRI, we can very clearly see, and we can see the extent. So we need to go in this direction, but also here, we can improve from the standard that we have. Well, we can improve our tissue contrast by giving contrast with MRI. And this is based on neovascular. And the reason why I do this rather lengthy preface is to understand why we actually need ultrafast and abbreviated protocols. MRI, even with the standard protocol, is an extremely sensitive test. Yeah, we have a high cancer detection rate. Sensitivity is in the high 90s, 97% in reviews. So, and why is that? Tumors grow leaky vessels, don't grow abnormal vessels, recruit new vessels, neovascularity as a tumor-specific feature, which is present as in lesions as small as 2 centimeters. These vessels are leaky, there's AV shunting, so the contrast agent goes earlier there and pools there. And here's already the word is it goes earlier there than the rest of the tissue. And in particular in dense breasts, there might also be normal uptake in the tissue, background parenchymal enhancement. So this would be a very dense breast. In this sense, there's a large cancer hidden, which was impossible to see on the mammogram, and also very small lesions. But if this patient would have a lot of background parenchymal enhancement, that might be not that easy to see. DC MRI is the backbone. While we can do other additional parameters, and I will also mention these briefly, DC MRI is our money shot sequence. This is the one where we really find the cancers. This is when we are thinking about providing that to a larger population for screening. This is the sequence that will be the backbone, the main sequence for a very long time. And when we look at what are we seeing, does it helps adding other modalities? Well, the majority of cancers we see with MRI alone. Mammography should still be in the mix when we think about the screening context for the calcification, but the majority, what we need to see, we will see with MRI. And this would be such a case here. This is a patient, young patient, BRCA positive, high risk screening. She undergoes MRI. Let me see if that works. Yes. And this is already one of all of the images that I'll be showing you are already high resolution MRIs. These are having a better temporal resolution than usual. Yeah. And you can see here there's a very small lesion, which is in this dense breast actually impossible to see. You see the patient is dense. We have here a small lesion, which showed an very early enhancement, suspicious. This was biopsied under MR guidance, and this turned out to be an early form of cancer. So this is another example where we see, again, very dense breast. This patient is just underserved with mammography in a high-risk setting. Again, another performed as a high-resolution MRI. Here you already see that there is more background. And the pictures I'm showing you here are all scans that are showing you the contrast enhancement within the first minute. So that is basically our windows of seeing cancers is in this early phase. And here we very nicely see here a linear non-mass enhancement that was again biopsied under MRI guidance, showing an early ductal carcinoma in situ. And also, this also has been confirmed in all large trials that what we need to offer our patients, most of the large trials are in high-risk patients, but there are also trials showing it in average-risk populations. MRI is the best way to go. When we want to offer our patients the best care, it has to be a vascular-based form of screening to show the neovascularity. And this has also changed screening recommendations. So women are now actually even recommended then when they are greater than average risk of breast cancer that they should have MRI, and if they cannot go, they have to have a vascular form of screening. And our DENSE trial actually has showed that this was a pivotal trial where women were offered, again, in very dense breasts, where they completely underserved with conventional imaging. They have showed that we find twice as many cancers, which has actually led to a renewal of recommendations across the world. And so we will only see these populations that we have to serve with MRI and where we should be seeing their cancers will only increase. Now, when we think about, we now have to serve a larger population for screening, we have to make this also cost effective. We have to be able to offer that to patients in have larger capacity, because standard MRI protocols are, when we acquire all our students, are relatively lengthy as compared to what we would need for screening. I mean, that you should perform MRI routinely at 1.5 Tesla, not below, ideally at 3 Tesla, where we get higher SNR and also gives us more leeway what we can do from an imaging protocol. While I just want to mention that 8 channel is good, preferentially 16 channel, because that actually also improves what you can do with your protocols. And when we are thinking about going to MRI to a broader population, we have to be fast, we have to be accurate, we have to give contrast, and we have to have excellent fat saturation. One thing I just want to mention in this context, because this is also contributing to helping our accuracies, is we should be using a high relaxivity contrast agent. And in particular, when we think in the context of screening, there are nowadays actually contrast agents available that allow you to give you half of the dose of the gadolinium while achieving the same image quality. So what we have to do is we have to high spatial resolution, high temporal resolution, and that now also here are certain variations. When we think of MRI, the protocols we have already have good resolution. Yeah, that is, we usually do a pre-contrast sequence, then we have at usually 1 minute to 90 seconds intervals, we acquire post-contrast scan. That is a standard protocol, which gives you the usual time points, but the problem, not the problem, but the thing is, when we think about when do we see the cancers show up in the first minute. After that, the background kicks in with the potential of masking small, more subtle lesions. This here is not a subtle lesion that I'm showing. That is a large cancer that it will most likely not be missed on a protocol, even if the patient has a lot of background. But first of all, there's an overlap between benign and malignant lesions that becomes more pronounced the later we are, because the benign findings in the background shows up later in the enhancement curve. Yeah. So if the idea of advanced protocols with fast, ultra fast, is to acquire more time points in the phase that is really important, the first minute. This here is kind of the concept of how we improve our MRI with high resolution protocols. There are two ways of going about this. It is faster, which gives you a sampling in every 10 to 15 seconds. That is the protocols I'm speaking here is applicable to both 1.5 Tesla and 3 Tesla. The rule is that at 3 Tesla, you can get a few seconds extra, but it is both doable at both field strength. And with the fast protocols, the spatial resolution stays the same as with the ones that you know from your standard protocol. With ultra-fast protocols, you have a higher temporal resolution, so you can get even more time points along your curve, but that makes you have to compromise on the spatial resolution in this ultra-fast block. Ultra-fast protocols are most often performed as hybrid. The faster protocol, which is what I'm currently using at my institution, is the schema is laid out here. We use a sequence that gives us multiple time points in the first 60 to 80 seconds. That is the phase where we see the cancers show up. And then in the delayed phase, we have the capability of making our blocks in the delayed phase longer for more SNR, that the difference is they look smoother. But again, we just recover the normal dynamic time span of 4.5 minutes with a higher resolution, in particular in the first minute or in the first 80 seconds, and keep the spatial resolution to that one that you are used to see from standard protocols. This would here be an example of such a faster protocol. This is a patient who actually underwent screening with MRI at our institution prior and always presented with relatively strong background and parenchymal enhancement in this bench press. This is a woman who is clearly underserved with mammography imaging. Yeah, but on top of that, she also has a marked background parenchymal enhancement. And what we noticed on this scan in this particular year is that she had enhancing masses in the very first minute of her. Like after phase 3, that is approximately 40 seconds into contrast. That is not what a benign lesion should do. And actually on the other side, we also noted focal areas of non-mass enhancement that were actually enhancing too early. We biopsied these patients. On the right side, it was a DCIS, ADH, and LCIS classic type. And on the other side, we also had all shades of high-risk lesions. So this is something which we actually picked out because we saw the cancer before it was masked by the background parenchymal enhancement. So similar to the breast density, background parenchymal enhancement can mask cancer. This is also another example, and this is basically to highlight, yes, this is a very suspicious lesion that is actually biopsy-proven cancer, but when you see when this cancer actually starts enhancing, this is basically immediately after the contrast goes into the heart and enters the breast. These lesions enhance rapidly. This is kind of the sweet spot where we want to land with our sequence to visualize the cancers the most. From these protocols, you can also get the normal curves. It just gives you more time points in the first early phase, and the delayed phase, you have then less time points by this protocol, which we actually also published in JCO. We published that protocol basically in the sense that we looked at our screening protocols before we went to these faster imaging protocols and compared it after the protocol switch. And what we actually found that you find, in particular in patients who have a high background parenchymal enhancement, you increase your cancer detection rate to 31.4 per thousand as compared to the 11.9 per thousand. So This is a significant additional cancer yield of 19.6, while we actually concomitantly decreased biopsies, because it's the next thing. We need also to make sure that our specificity remains good and we are not doing too much unnecessary biopsy. Ultrafast is exactly the same concept, but the idea is to provide even more time points in the first minute. That comes at the expense of a lower spatial resolution, which then is usually mitigated that in these protocols, these are a hybrid type, where you actually have then your standard classical high spatial resolution sequences at the end. You get more granular information, and in all fairness, to be frank, what protocol, whether you want to go with an ultrafast protocol or a fast protocol, will be your reporting radiologist's preference. They are equally good at weeding out the cancers. A ultrafast protocol gives you more granular information in the first minute, and it also will depend on personal experience. It will depend on what your vendor is, because ultrafast protocols are ideally, the ultrafast part is ideally displayed as a cine loop. As a cine loop that you on your workstation, that you review that up front as a cine loop, you see the contrast flowing in, see when the early enhancement of the cancers is there or not, and then you go to the high resolution protocol. Some vendors can display it as that. Some vendors do not have the capability to do the cine loop. So what you in the end, they end up doing for your screening protocols, faster or ultrafast, will be preference, as well as I think really also vendor dependence. Yeah, and these are publications from where our Asian colleagues and our Dutch colleagues have published a lot on ultrafast, where they show similar results. You find the cancers before they are hidden within the background noise of the normal breast tissue. There have been endeavors to actually take this higher resolution concept also to spatial heights, so to speak, and looked at 7 Tesla protocols. The one thing is the question, do we really need that in our radiologist life? I don't think so. We are already very, very good when it comes to spatial resolution at 3 Tesla. And with this additional information of the enhancing our temporal resolution while keeping the spatial resolution, that is sufficient. 7 because with a higher field strength and a higher come other problems due to star restrictions that you have. You cannot perform normal T2-weighted imaging. I think this, for the time being, this will remain in the research realm. When you think about are these fast protocols, ultra-fast protocols, to maximize our diagnostic accuracy, to maximize our capacity and what we can offer our patients, I think we also should think a little bit of the sequence order, and this is something which we have implemented in our clinical practice. The contrast enhanced part is the money shot. This is where you see the cancers. This will determine, does this patient need a biopsy? Or is this patient a normal exam and does not need anything else? Traditionally, you perform the T2 and also diffusion-weighted sequences are performed before contrast. But in my practice, we have encountered that patients, when they're already nervous or they're moved, you have a T2-weighted sequence. Sometimes and then this T2-weighted sequence gets repeated because there are too many motion artifacts. Then you start your money shot sequence almost 8 minutes in for the patient. This is the best way to maximize your motion artifacts in the contrast-enhanced scan. In my institution, we start with our T1 without FATSET. This is the clip-seeking sequence. And then we just want to go straight to our dynamic contrast-enhanced scan, and everything else comes afterward. Because cancer, yes, no, comes from the contrast-enhanced sequence. Diffusion and T2 add specificity, but they are not deciding whether you want this patient, whether there is something suspicious, yes or not. And it has been shown that there is in studies that there's no image on diagnostic accuracy if the T2-weighted exam or the diffusion-weighted exam is performed after contrast. What you also encounter, where also this ultra-fast and fast sequence might actually be beneficial, is when you have patient motion. Motion correction software can be helpful, like in this case, where you see the small cancer here, which was completely invisible, which was masked here by those subtraction artifacts. But sometimes even the best motion correction software will not help you. If a patient is moving too much, this will not work. But these motion artifacts are not necessarily present in all exams. So in all sequences, on all phases that you have available for reporting. So this is here an example of one of our fast protocols. In this phase here, there is pronounced motion, which is not present in the other one. So that actually might give you an opportunity to actually review, have a better window on what you can diagnose. And also when we think about offering screening to our patients and increasing capacity, abbreviated MRI protocols have been developed, but so far they are usually standard protocols. So that means you have one time point before contrast and one time point after contrast. Well, with fast and ultrafast protocols, we can give you more information even in an abbreviated MRI protocol, because you now, instead of one point, you have multiple time points after contrast. You get kinetic information, even out of an abbreviated protocol, and abbreviated protocols will be the way to go for screening. So the combination of fast, ultrafast, and abbreviation will actually enable us to get our more MRI exams to the women. This is the seminal study from Christiane Kuhl, where she introduced the concept of an abbreviated MRI protocol, just utilizing the phase before and 1 minute after post-contrast. And I mean, it stands to reason. This is exactly the time frame in which we see the cancer. This concept has then also been explored by in ECOG-ACTRAN by Chris Comstock, where we looked at tomosynthesis for screening and abbreviated MRIs, and they showed what we have seen also now in dense. You find twice as many cancers. Yeah? But when we can also now improve these MRIs to that extent that we also take out the component of the BPE and make even abbreviated MRI very sensitive, that can be really, I think, a crucial breakdown in breast MRI women. Abbreviated breast MRIs, there's a lot of evidence that they work. They have, and we're thinking here about what parameter should we look at? Sensitivity, because we want to find the cancer. Yeah, this is like with mammography screening. Is it a recall? Yes or no? This is the approach for screening abbreviated MRI. Recall, yes or no? And to make you in this context the same sensitivity, but make you even probably more specific, that would be also great use for these ultra-fast protocols. And this was a study where we actually explored the concept for abbreviated MRI at a high-risk screening, because this is where you can simulate protocols very well. These women get screened for breast cancer, and we looked here with a simulated abbreviated protocol. Does that actually work? Do we lose sensitivity, or is there value for adding additional sequences? And what we actually showed here, abbreviated protocols work also in the high-risk screening cohort. You do not have to go to a full protocol. If you want to go at a T2-weighted exam, you improve your diagnostic accuracy, but with an abbreviated protocol, you are as sensitive as with a full protocol, which is kind of very encouraging in this abbreviated, to add on knowledge that we can go down that route. But when we think about going to full abbreviation, I really think we need to go with ultra-fast, fast protocols. Yeah, so abbreviated MRI alone have a good diagnostic performance, but you can add specificity when you do additional sequences. And when BI-RADS, and I think it's now safe to say that the BI-RADS Atlas actually will be out with RSNA, so we should be getting our new MR BI-RADS in RSNA is in 3 weeks, so very shortly. There is also accounted for that there are high resolution protocols now, that these can be utilized, that they have value. There's also information on abbreviated MRI protocols in there, and also the section on diffusion is expanded. Why am I mentioning that? Diffusion is still optional, but it is recommended. And when we think about how we can improve our MRI protocols, yeah, and how we get this into the screening realm without compromising on specificity, that is also a thing to think about for adding. So it's a fast technique, takes 3 minutes or less, and can help us distinguish between benign and malignant. So the lesion that we see already enhancing can we add additional information on what that is and limit protocols? In clinical practice, multiparametric is diffusion T2 and DC MRI, and it works. We know that. It adds specificity. DC MRI is the money shot, and in my opinion will for the longest time be the sequence that will be the backbone of anything we do in breast MRI, but adding more functional information helps. This would be here how you interpret diffusion weighted imaging. You look at the high p value if there is a restricted or hindered diffusivity, and then you go to the ADC map, and actually you have to actually measure it, because everything below 1.3 is considered suspicious. And to get this into a reading algorithm, and there will be also more guidance in the BI-RADS Atlas on this, how to really incorporate it in your reading life. You look at your DC MRI exam, you take the BI-RADS descriptors that we have, look at shape, margin, the functional parameters. You also will can look at T2 weighted imaging, but then you can actually look how is this lesion behaving on diffusion weighted imaging. You already have an idea, usually a very good idea of what you think this lesion will be, but then this adds diagnostic confidence. Yeah, so this was a fibroadenoma. Here, that is a lesion where you already have a very good idea that you think this is malignant. An additional diffusion weighted exam that gives you this confidence, gives you additional confidence. And this actually also can work in lesions as small as that, where this was a high-risk screening patient with a new 3mm mass. Yeah? We actually could see this lesion, and it was actually confirmative that this is actually a suspicious finding and needs a biopsy. And in this high-risk screeners, we do aim to minimize unnecessary procedures as much as we can, but our alert level is also a different one. And this is here a patient who actually presented with a palpable area of concern, where we actually in ultrasound mammo, not very informative, but we find this mass. She actually undergoes an MRI after this lesion had proven to be malignant, and we actually see her cancer and a benign lesion on the other side. But what we also found is in the same breast of the cancer, we suddenly see a lesion that we had not seen before. This is suspicious enhancement, actually also ADC, suggestive of malignancy. We then went to an MRI-directed second look ultrasound and found another cancerous mass. So this high-resolution protocols enhanced by functional image can really help us. This is one I want to mention because the question I have gotten lately relatively often, how good is actually diffusion in the axilla? Well, if the lesion is consumed by cancer, the lymph node, it behaves like a cancer. There is an overlap between benign and malignant ADC values. You cannot just interpolate the ADC threshold onto the lymph nodes. If they are really low, they are suspicious, but if they are just below 1.3, don't go chasing after lymph nodes that look normal on a sonogram. Because this is a question I have been repeatedly at meetings. Lymph nodes, even with ultrafast and advanced protocols, are still the test to actually look at them as ultrasound. You will see them. They may seem prominent. They do enhance. Yeah. So for those ones, if the question is what I should do with those, take a step back and go to the good old ultrasound, because a node that can be seen prominent on MRI does not necessarily is that on actual conventional ultrasound imaging, and that is the way to go. Limitations of diffusion weighted imaging are where, and that is why DCE, when in doubt, go with what your DCE protocol tells you. Actually, shown very nicely also from Dali, is that we are limited in non-mass enhancing lesions. So that is where the contrast still wins. There will be technical improvements, so that there have already been a lot. So look out for those more. I think when we go into higher spatial resolutions with that, this might be extremely attractive to add to our screening roster with combined, also deep learning is heavily pushing into the realm here. Deep learning reconstructions are actually, you're often not aware that you actually would have that on new GE magnets. Diffusion as a deep learning reconstructions are actually a product which you can utilize, and I do on a daily practice. I'm currently performing my diffusions with deep learning reconstructions, which basically improves your image quality. Yeah, you can either make yourself faster with the same image quality, or you can improve the quality of your scan. So this is here an example where Muse would actually be the better sequence from a technical point of view, but with deep learning reconstructions, you can actually get the same and even more granular information with that. So if you have that available, check in. As if you have a GE and a neuromagnet, check in with your vendor if that is actually available to you. So, and when we think about, we have now an abbreviated MRI protocol which we want to offer for screening. We actually have now ultrafast and faster protocols that give us more information in the first minute to inform on whether there is a suspicious lesion, yes or no. Consider actually also adding this diffusion weighted concept in the mix. And if you have a very good spatial resolution, the idea would be at one point that we can also kind of replace T2 weighted information with that, because a DB0 image is just T2 weighted information. So to sum up, what do we currently have when it comes to MRI? Well, MRI is undoubtedly, regardless of what imaging protocol you perform, the most sensitive test for breast cancer detection with a good specificity. You have to perform high quality MRIs, yeah, and I mean, we all aim to do that. Sometimes you are limited what the patient is giving you when they're moving too much. That there are things that you cannot control, but if you perform high quality MRI, that is the key to success. High resolution protocols have been consistently shown to improve diagnostic accuracy, both from a temporal and spatial resolution, and MRI is the exam recommended for high-risk screening, and with the tentative recommendation that we should offer that to women who are greater than average risk of breast cancer, our screening population can only increase, and we have to make sure that we can really offer that. Ways for this one are abbreviated MRI protocols, but we want to get also the maximum information out of those. And this is where ultrafast and fast protocols are most definitely the way to go. This is a breast mammography called, and there is a massive cancer sitting there. This was shown with MRI. Yeah, diffusion remains optional, but I hope I have convinced you to some extent that at least give it a try and to incorporate in your protocols. But what I also want to highlight, the money shot is the contrast. Diffusion and also T2 can be performed after that without impacting diagnostic accuracy. Multiparametric MRI protocols are the way to maximize your diagnostic accuracy, and can also be bundled up in abbreviated protocols and should be actually paired with fast and ultrafast to obviate as many unnecessary biopsies that we actually have. Yeah, and most scanners nowadays can give you some. If you cannot push your scanner to an ultrafast protocol, you can do some form of faster imaging. And I would really encourage you, if you have the option to play around with your protocols, do that. It has really significantly improved our cancer detection rate. And once we had our study where we showed moving from a standard protocol to a fast protocol with 19.6 incremental cancer detection rate addition, that was eye-opening for our service. So with this, I want to conclude, and I'm happy to answer as many questions as you might have.
Thank you. Thank you so much, Katja, for such a fascinating talk. Yeah, every time we listen to you, we remind how science and technology and clinical care can come together so beautiful. So it's always a pleasure to have you here at SIBIM. We are super happy. And yes, we can move on now for the Q&As as part of the session. So please feel free to send your thoughts, some questions. I would like to start with some asking from your experience, which patients do you think this kind of ultrafast or abbreviated adds the most value compared to this full protocol of MRI?
I mean, we do it in everybody. I do fast protocols in everybody, but if I would have to select the young screening patient, because who has a lot of PPE? The young woman with the dense breast that presents for screening. These are the ones where these are the women who actually also gets so many biopsies over the course of her life. So if I would have to select somebody, it would be a dense breast and in a young woman that presents for MRI screening. I mean, like, I don't have to choose. I perform it in everybody. I'm as fortunate to have magnets where all can do that. But if I would have to decide which ones, it is the screening population, the young women with the dense breast.
Yeah.
That's also why I tried to make this screening point with my discussion, because it comes up more and more. We are moving into vascular based screening, and this is like the one thing is you always want to avoid when a patient comes for a baseline exam. You do not want to recommend additional imaging. You do not want to recommend a biopsy, because you do not want to traumatize the person showing up on her first exam that you recommend interventions. That is so anything that makes you better here to minimize the anxiety and the trauma, that the next time they show up, they will be a nervous wreck, even if it turned out to be nothing. So
absolutely,
this is
yeah. So now thinking about the daily clinical work. So what are some of the main challenges you have in the implementation, like technical for these protocols?
The thing is, it is a fact, your scanner has to be a certain age. Yeah.
Okay.
The scanner has to be a certain age. It cannot be a very old magnet. I mean, like we still have sites where they are good magnets to good diagnostic imaging with a standard protocol, but it is impossible to go to this high, just even to a faster, not even ultra fast protocol. You will be. That's also why I mentioned coil technology and field strength. It is easier to implement a 3 Tesla with a 16-channel coil in a new magnet. But some iteration can be performed also on older magnets. If they're too old, you will not be able. From an implementation process, once you have the protocol on the magnet, from a technologist perspective, it is actually more convenient to perform a faster protocol, because there's no delay. They start the scan when they inject, and then they wait the 4.5 minutes. The subtractions are calculated automatically. And that is basically, from a technologist uptake perspective, that is smooth. The one thing what I have seen when we did a hybrid protocol was what technologists didn't like. If you do a hybrid protocol, you have to do 2 pre's, because you want subtraction from the high resolution part in the late phase, and you want the subtraction for the ultra fast part. That is manual work for them, because now they have to actually calculate subtraction. It doesn't come automatically. But it is just like they have to do more clicks, and I do understand that they would like to avoid that. But it is not, from an understanding perspective, the implementation is actually a very smooth one, I would say.
Dali, I have a question.
That's fascinating. Yeah. Go ahead.
Dr. Katja, if you have contrast enhanced mammography and MRI, what do you prefer for dense breast screening today and in the future?
So I prefer an MRI, but I mean, I fully acknowledge that contrast enhanced mammography is an extremely valuable test. If it comes to what can I wish for? I mean, the women who can get an MRI should get an MRI. In the world I work, a lot of women don't. Only 20% lifetime risk or up do get the MRI. But I know that they are so underserved with just a mammogram or a tomo. I mean, when I mean mammogram, all of our mammograms are performed as tomo. Of course, I immediately want a contrast enhanced mammogram. We actually offer now contrast enhanced mammograms in women who are just dense, where don't even are greater than average risk. That is like we are now offering that, because we know that these women are underserved. In an ideal world, if everybody can get an MRI, but I'm a realist. I know what is feasible. Vascular-based form of screening, and contrast enhanced mammogram is an extremely valuable test in this context.
Okay, thank you.
Absolutely. Yeah. So looking ahead, how do you see, of course, AI supporting or even transforming the use of this kind of ultrafast or abbreviated MRI? You already talk about that, and I love the images that I saw in your talk. So what's the near future for that?
I mean, the
I
next
hear
thing
you
is
already using.
It's the next thing is like we have for mammo will be a cat. It will be a cat for MRI. I mean, every vendor is working on that. Yeah, and I mean,
Everyone.
similar with why do I like to have in particular to have a cat when I read a tomo exam. Tomo, everybody knows we're scrolling through the tomo slices and finding lesion. If a CAD system just shows you the slides where there is the finding, yeah, extremely helpful. I mean, Ultrafast and Fast gives you tons of more phases to look at. Yeah, a Fast protocol, you have 9 phases in total. Yeah, with an Ultrafast, we are talking about 30 phases usually. Yeah, I mean, if would be a CAD system that brings like in phase X, you see a suspicious enhancing mass that it is just like it is already in the making. This will enter the realm first. AI is for sequence optimization is already there, like I showed for the deep learning reconstructions, and this will only grow and more. Currently the deep learning is kind of like a little bit challenged in diagnostic contrast enhanced exams. They seem to be easier to do in T2 and diffusion where you do not have multiple dynamic frames, but it's also something that is bound to happen. As I know that AI will enhance the way we work.
Thank you.
We
have in the chat a last question, maybe, Luciano?
Yes, we have a question here. The question is, if after acquire the pre-contrast images, when you inject the gadolinium, do you start acquiring images as soon as you begin the injections, or
yes,
do you
that
wait
is
a few seconds?
That is the beauty of this Ultrafast and Fast protocols. You inject and start, and then you really see first phase is always black. Yeah. Then in the second phase you see the heart coming up.
Okay.
Yeah. Then you actually know the contrast is in the patient. Yeah. And then of the third phase you already see it in the breast. Yeah. So it is like we just think that is like you really can show that is the cine loop of the Ultrafast. That's why they are actually also so preferred to be viewed as like in this loop where you see the contrast flush in, and then you really see first you see the suspicious things lighting up, and then you see the blush of the background parenchymal enhancement. And then in particular, Rita Mann has often shows very, very interesting cases where you see cancer, poof, and suddenly is the background there. You don't see anything anymore. And this is the beauty of it.
We have another yes, Dali, please.
Yeah. Following, because we have some time, we have a question about the issues we could have with the biopsy cases, the lesions only seen in. I mean, what we can miss and we can not see, in this Ultrafast.
The thing is, when the question false negative in Ultraman, they do have exactly the false negative and false positive rates that you have for a standard protocol. I think what it probably is meant is how does this look for abbreviated protocols? With abbreviated protocols, we really cutting away some part of our protocol. And
that's it.
In theory, well, the low-grade DCIS that we only see in the delayed phase or the very diffuse lobular, this we potentially could miss. I mean, I'm not so sure if I'm really so sad that I missed the low-grade DCIS. The lobular, I wouldn't think it is a good thing. But in all fairness, at the top of my head, I cannot recall cases like that. So I have to, admittedly, with an abbreviated protocol, there is this chance. But for Ultrafast and Fast, since you're sampling the same time span that you would with a full protocol, the false negative rate will be the same as a standard protocol.
Yeah. So do we have time, Luciano? People is now asking. What do you think? One more? We have
sure, I mean, I have
2
time.
minutes,
It's like
3 minutes.
It's like
we can.
I'm happy that my phone held up the connection for as long as it could, and also you can still see me with the light being now completely dark outside.
Excellent. So, it's possible to implement the protocol in a 1.5 Tesla. Yeah,
we have done that. We have a 1.5 Tesla GER test where we have implemented. The difference is this is like when you want to maintain the same spatial resolution, you will not be at 12 seconds every phase in the first minute. You will be at 14 or 15 seconds, or you will probably not be as a slice thickness of 1.1, but you will be at 1.3. Honestly, it makes no difference from a diagnostic perspective. Yeah, so it is definitely possible at both field strengths. It can also be 8-channel coils. So it is that the magnets are all. I do think that all of the magnets, if they're not really old, can give you some shape or form of possible being faster.
Yeah, but for at least for the ultrafast, we need a special sequences, right?
The sequences, they are the standard, that they are vibe sequence. The one thing is with the ultrafast, it will depend on how much you are willing to compromise on the spatial resolution. You can do 4 or 5 seconds, but then your spatial resolution is not great. But the idea here is to see the dot come up very early, and then you will have to perform one of your standard blocks that you are used to be doing.
Kind of the diffusion force images that
it's basically you have some things that come up, and then afterwards you do actually your standard sequence that you would do to have the morphologic information on that.
Yeah, awesome. Thank you. I think, Luciano, we are done here.
Yes, well, we have one more question.
One more?
Sure.
Okay, last one.
More? Okay. The Christy Martinez, in breast reconstruction with or without implant, we could use the ultrafast sequences.
Yes, it is. Yeah. The thing is, like the implants, there's no limitations from an implant perspective. That works as well. Yeah, actually, we know an implant doing regular mammals is often not not. I mean, you can do it. An implant displaced views, but you might miss something here. Yeah, that is fine. What you notice on the ultrafast sequences, but you do not use that contrast enhanced sequence to evaluate the implant. So actually, who cares how the implant looks? What you will see with these fast sequences, the implants change their signal intensity. Sometimes they are on one, they are hyper, that because that is due to the rapidly switching of the gradients. If you want the implant integrity, you will have to do implant sequences anyway. So ignore how the implants look on your dynamics, and you want the breast tissue information, and that is as good as without implant.
Okay. Well,
thank you once again, Dr. Katja, Dr. Pinker, because of course, your time, your expertise, everything. We are super happy. Thank you everyone for joining us today. It's truly a very enriched session. On behalf of SIBIM, we appreciate everyone, their participation, and look forward to seeing everyone in the future events. And have a wonderful evening.
Thank you very much, everyone. Thanks for having me. Have a great evening. Thank you. Bye.
Okay. Thank you, Dr. Katja. Bye. Thank you, everyone. Okay.